Hi everyone, my name is Kelly Coulter and this is Meant to Pause, a podcast devoted to the process of menopause, what it actually means to so many of us women, and all of the information that we need to know more about. So I've invited many guests on our show, and today I'm very happy to introduce Farrelly Vanderschilden. She is an orthopedic and pelvic health physiotherapist at Rise Health. She lives in Victoria, which is where we're filming today, with her wife and 2 children. So welcome, Farrelly, for coming. I know that this is kind of new for you. So how are you feeling?
I will be a star shortly.
Yeah, you're going to do great. So many of the women that have come on our show they're not accustomed to being on film or being on a podcast, basically. Because this subject is so important to us, I'm really thankful that you have chosen to be with us today. So thank you for that.
Well, thanks for inviting me.
Maybe if you could just start out by telling us exactly it is what that you do and how it relates to menopause. I've been researching menopause for a long time, and I'm like, pelvic floor health? What is that?
So I have been a physio now for 15 years, and I got into pelvic health after having my first child. Pelvic health physio is essentially checking the ability of a person to engage their pelvic floor, and that usually revolves around things like continence, pelvic pain, prolapse, and sometimes some bladder conditions. I wanted to really close the gap in some of the areas that I was treating orthopedically, because I was seeing a lot of people with a uterus who were having some challenges, and I thought it was more related to their pelvic health than it was their orthopedic condition. So I decided to get that training, and lo and behold, that's actually what I found is a real shift in the way I view the world in terms of my work. So when I have someone coming in and they are complaining of low back pain, it doesn't matter who they are, then I'm always asking them questions about their pelvic health. I'm always asking them things like, how are their bowel movements? How are their bladder function? Are they having any discomfort in certain areas like their tailbone? What is their obstetric history if they have that? So all of these things that have really come into play, and we've managed to kind of weed out maybe a real origin that was deeper. Pelvic health is becoming a lot more mainstream.
Right.
There's a lot more practitioners offering this type of work. It used to be very niche, and there used to only be a couple practitioners on the island who do it. And now we are into, I think we have about 30 of us on the island now.
Do you find that on a global scale as well, that people are,
pelvic health, thankfully for all of us, is actually very in vogue right now. So there's a lot of courses. I know. Yeah. So there's a lot of courses. All of our physiotherapy programs offer courses that are beyond your degrees. And there's a lot that are in pelvic health right now because it is in such high demand, because people are realizing that things can be better.
Yeah. Women's health has not been a priority historically.
Yeah.
How does that relate to this surge in pelvic health?
Oh yeah, there's definitely a lot more research and literature that's coming out that can explain things in a far superior way than it had, and people recognizing again that there's things that they can do for themselves, or that there are practitioners that support certain conditions and they can seek that out. It is available. So a lot of times people just weren't aware of that. And again, a lot more research actually delving into some of the questions that are only centered around people with the uterus, women, which weren't historically the case.
So with regards to menopause, I think it's important because our audience is not just women, people who are experiencing menopause, but it's actually aimed for people who are preparing for, experiencing, and I like to say who have conquered menopause, right? how the pelvic floor, when you're preparing for, I call it the peri-meno post experience. So maybe give us an idea of like how things are in your peri phase and then what might happen during the course of the entire journey.
So what I tend to see in practice is that people who are coming in and they're perimenopause, they may not necessarily know that they are perimenopause.
Most don't.
No.
Yeah.
And they're starting to exhibit some symptoms where what typically comes my way is that they're having pain with sex. That's the number one I see. And that generally relates to when we're starting to see different changes in the estrogen levels, then we start to see changes in the vaginal tissue. And then that can become uncomfortable. So we can see that happen on a bit more of a cyclical level because they're technically still cycling and menstruation hasn't stopped yet. So they are finding that they're having periods where this is worse and not.
I can imagine that when you tell them that they're perimenopausal and that's the reason for this pain, there must be this sense of like relief on one hand, but then, oh my God, I'm going into menopause. Like,
but it seems like most people are relieved to know that it's not all in their head because they're thinking, oh my gosh. And again, if it's something that there are things that we can suggest, therapies that we can support them with, or suggest that they see another allied health professional, then they know they've got a team that can support them. So then they can kind of head into it kind of ready and able.
Awesome.
Yeah.
I have to say, because you've attended one of our gatherings, we do gatherings about menopause for my sister's house. We're doing it here in Victoria and they've been great. And we've had so many great speakers, including yourself. So fun for me when I see everybody just kind of looking at each other when new information comes up and they're like, oh my God, I didn't know this. And when you spoke, there were some things that you told us that were like, oh my, I saw heads exploding in the room. It was like, oh my God. Yeah. So that's the perimenopause. Is there anything else you want to add to that or?
So that's the most typical presentation that we see. And then when people are starting to move, they've either officially moved into menopause now, they've stopped menstruating and it's been for a time, then the typical presentation that's coming to me, they're not coming to me because, oh, I'm in menopause and I want to come see you for public health. What they're usually coming for is that they're now experiencing some incontinence that wasn't present before, often coupled with pain with sex. And sometimes they're getting a bit of discomfort just around the pelvic floor. But generally speaking, it's the new onset of incontinence. And what we typically attribute that to is that when we have now had a drop in estrogen, the vaginal tissue is now not plump. And so that is part of the continence function where it kind of squeezes the urethra together to kind of pinch it. And then now when it can't do that because it's thinner, then there's a gap in that the body's never had to make up before. And suddenly it's now left with a deficit and it doesn't know what to do with it. But again, if we educate people on that and then we give them the right strategies, and then what I would always do is check that they are able to engage their pelvic floor the way that they intend and then get them stronger. Usually we see it go away. And that's also a time where I can't speak to them about HRT, but topical vaginal estrogen is something that we tend to recommend at that point because that will bring back estrogen to the tissue and then help plump it back up.
Oh, so now we're going into solutions, right? And so this is again with the head exploding. I love it when we get to talk to experts like yourself, which is why I'm so thankful that we're able to do this podcast because it really is empowering, right? To get this information. So going into the, as I call it, the conquering phase, but going into the post-menopause, what have you seen there with pelvic floor health?
So again, often we're seeing kind of a combination of what people are kind of newly into menopause and they've long-term into menopause. Often what I'm seeing is that the people who have conquered menopause, they maybe could have done some aspects a little bit better with a bit more information, but that's also because that was not readily available to them. Right. So they're coming to me and they're seeking information, and then we may even be trialing them on some of the things I would get someone doing immediately after they've initiated into menopause, because it's never too late.
I think you should write a book about this, Caroline. To be honest,
who has time?
I know.
Maybe down the line, we'll see.
Yeah.
Yeah.
Going back to knowledge is power, right? And very fortunate here in Canada that we can access healthcare experts like yourself,
Mm-hmm.
there's a point of privilege there for many of us. I don't want to get stuck on that, but let's just say that, we're very, very fortunate. I wish some of this was available to everyone.
Yeah. And I mean,
Do you have any?
yeah.
I guess I want to ask you, what are your thoughts on that?
Well, I think we are definitely at a time where there is a lot more information available. And even as myself being a physio, I can see that physio is expensive, and pelvic health physiotherapy can be a bit of a barrier attending for some people. What I do find is that even just getting all the information and having their own program and kind of having a to-do list can set someone up to be doing things for themselves and not require a huge amount of kind of in-clinic treatment. So if someone's wondering if it'd be worthwhile for them, there is always a lot of information that they can get. And it might even just be a one-time thing. And if you're seeing a practitioner to just say that that's how it has to be, we can work within that. So there's no one's going to be upset by that. I'd rather know straight up that, okay, then let's do a plan for the next 6 months.
So when you talked about topical hormone replacement, maybe can you expand on that?
Sure.
If you want to add anything to that with regards to HRT, because it is, it's a huge subject in the menopause conversation.
Totally. HRT is a bit out of my scope, but when it relates specifically to the pelvic floor, there isn't a lot of great research supporting the pelvic floor aspect of it.
Okay.
So if someone was purely taking HRT only to help with pelvic floor symptoms, it wouldn't be indicated based on the research. That's again where the topical estrogen would be coming in. So there's a couple different forms. So it can be as a capsule that is placed vaginally. It can be as a ring that's placed internally. It can be topical creams that are placed outside the vulva and vaginal opening. So it can all be, there's different applications, and they are prescription because they do have hormone in it.
So do you have to go to a gynecologist to get these?
GP would be fine.
You could go to a GP and get these.
Yep.
Well, that is helpful.
Yep. Or if you have a naturopath that you trust, and if they have the prescribing ability, they can do that as well.
Oh,
and
naturopaths are big here on the island.
Yep. And a lot of them have prescribing capability. So that'd be something, if that's what you were seeking, you can also ask them ahead if they have that ability to do that.
That's a good tip.
Yep. And they can even do.
Thank you for that.
Yeah, no, it's a great one. And then and they can also do compounded ones for some presentations that require more personalized kind of prescription. They can make adjustments.
So the compounded ones would come from the naturopath typically, I'm assuming?
I tend to see it more with naturopaths because they are willing to not go off the books a little bit, but to apply things in a bit of a different manner. The GPs tend to keep it pretty strict. I'm sure gynecologists in specific situations would be doing that, but it's not required to go see a gynecologist because that'll take you a year. So let's not wait.
When you first started out with the pelvic floor, with your studies, how long ago was that?
That was 8 years ago.
Was this topical HRT treatment available 8 years? It was. Yeah. Okay.
It was an if you know, you know type situation. It didn't seem like it was readily available.
Right.
Because it did come up in some of our coursework, and even for things like for people who have birthed a child, when they're breastfeeding, their estrogen drops, so they can kind of go into from a tissue standpoint, kind of a menopause state. And so that's a time where you can also have that prescribed when you are postpartum.
I'm sorry. I'm thinking about,
I know, mind blown right here.
I'm thinking about, did you ever watch that episode of Sex and the City?
I've seen them all.
Right. Okay. So there was an episode of Sex and the City where Samantha she was on a yam craze.
Yep. For the estrogen, yep.
But I'll never forget that. Just in what we're talking about right now, like you've already told me a couple of things. I'm like, I didn't know that.
Well, and I would say, pardon my interruption, like to clarify on the topical estrogen, there, like a lot of people have fear about estrogen because of breast cancer.
Yes.
But I just like to clarify, and there's a lot of research, it is not systemically absorbed. So for anyone who's afraid, they have a family history, they have a personal history,
good to know.
It is safe to do. But they should inquire with their healthcare provider about questions with that. And if their healthcare provider is worth their weight in salt, then they should know that it is not systemically absorbed.
So in layman's terms, systemically absorbed means...
It doesn't go into the body. It only stays at the vagina.
Going back to the Samantha and Sex and the City. So there are these like little hacks, right? I call them like, I have like personally every day I'm like discovering a weird new life hack. And
Yeah.
I'm like, how come I didn't know this before? So for the purpose of, the people that are preparing for experiencing and have conquered menopause, can you give us any give us some hacks?
Well, I would say that if you're starting to notice any irritation, any tissue integrity issues, like you can start with using just lube, just regular lube, just as kind of a moisturizer, like you would moisturize your face. Yeah. But make sure it is something that is designed to be on your labia or internal. So lube, for people who don't have any coconut sensitivities, coconut oil is one that's kind of a long-standing history, and there's even some antiseptic properties in it. But that's a personal, make sure that you don't.
Coconut oil?
Yeah.
Oil.
Yeah.
Okay.
Yep, as a moisturizer.
Yeah.
Some people will use even Vaseline in the labia.
Yeah.
I myself sometimes use a CeraVe ointment that's meant for diaper rash for babies, but they have an adult version. It's just cheaper for the baby one, so get the baby one.
Okay.
Yep, and those are just things to help keep moisture in, and if you're finding that you're experiencing any dryness. So I mean, things like that where you can start to treat it before it becomes a problem.
Yeah.
And if you're noticing something doesn't quite feel right, then try some things that are just off the counter.
So thank you for that. Is there any other hack maybe?
Well, I mean, staying strong.
I'm thinking of exercise.
Yeah, just in general, exercises, right?
Yeah.
That's great for your bone health.
Yeah.
Right. That's great for maintaining stability around the pelvis. And if we are strong externally, that allows our pelvic floor to do what it's meant to do. So it's not then working it's not working in a stability function. It's working, or not working overly in a stability function. It's working to do its stability and continence function.
Kegel comes to mind.
Yeah. Kegels are a great exercise. You just got to make sure that you're doing them right. So
that'll be another episode.
Well,
maybe.
yeah, and that's the number one thing I found, that before becoming certified in this type of work, before I was able to do any type of internal work, I would be telling people to be doing that, and I would be doing all the typical cues that we would be taught. And when I was able to then do an internal assessment and check that what was being engaged was what was intended, I would say that over half the time it's not. So, so just if you have any questions about it, that maybe seeing someone, because if you just read something online and go, okay, then you're squeezing or you're stopping the flow of urine on the toilet, that is way out. We don't do that anymore, because then that's actually really kind of confusing for your body. Yeah, because it's like, but I thought I'm peeing.
So actually, one of the things that you told us during the gathering that really, I think it freaked all of the women out, is that the long-term care stats, and that do you want to go to that? One
of the main reasons someone moves into long-term care is that they're incontinent, and family and caregivers are no longer able to care for that.
I found that
person. Yeah,
just like if there's one thing that would keep you motivated to take better care of your pelvic floor health, that would be the greatest motivator. Not just I want to be healthy or strong. It's like I want to live in my own home for as long as possible, and quality, not quantity. Correct. Okay, I'm leaving this subject till towards the end, because it was the subject that I had no idea about when you were speaking at the gathering, that I was like, pardon me? Does that really happen? So what I'm referring to is pelvic organ prolapse. And there was a lot of discussion around that. There were actually people attending that had experienced it. So maybe if you could tell our audience exactly what it is, and then speak to potential treatment or anything that you can add, because this is something that is kind of happens around menopause, or am I wrong?
It can get worse at menopause.
Okay. Yeah. So maybe give us an overview.
Yeah. So pelvic organ prolapse is when we have 4 different varieties in a person with a vagina. So we have when the urethra is now sitting lower, We have the bladder sitting lower, we have the uterus sitting lower, we have the rectum sitting lower. And what we mean there is that there's been maybe some tissue damage. Some people have collagen disorders that make them a little bit more loose in their ligaments, and things are allowed to sag a bit lower than they were originally, maybe prior to carrying a child. That's one of the most typical onsets. It occurs in 30 to 50% of people with a uterus.
Oh, that's high.
It's very high, but it doesn't mean of all of them. You could have a single type of prolapse at any given time. You don't need all of those all at once.
Okay.
Yeah, which would be scary. And we grade them on, there's a couple different ways to grade them depending on if you're a gynecologist or if you're a public health physiotherapist, but generally we grade them on a scale of 0 to 4. So 0 meaning nothing. And then 4 is when we're moving into kind of something is coming outside of the body that is not meant to be.
Yes.
But the good news is that generally speaking, it's often asymptomatic. So when someone comes in and they've gotten a diagnosis of prolapse, not always is the case that they've actually sought that diagnosis. It maybe was they were having a checkup with their GP, or they saw their gynecologist for something else, and they said, "Oh, and you've got a prolapse," and they didn't really explain any of that what that was, and they maybe were not having any symptoms related to that. And so, from our standpoint, it's nothing to worry about if it's not bothering you.
Oh
in
my
any way.
goodness!
Yeah,
thank you. You've just taken all of like the because I'm like, I don't even know if I want to talk about this because it was so scary to me. So It sounds scary.
Exactly. So when someone comes in, I say like, oh, like I don't like using the P word because, bodies change. And so what happens, if you have, again, if you have a collagen disorder or you've carried a child to term, or if you've had multiple pregnancies, those all increase risk because there's been more stress. If you are overweight, that's lots of load onto the pelvic floor. So all of these things are risk factors. Okay. But generally speaking, with pelvic health physiotherapy, the research suggests that we can move the person back a grade unless they're at the final grade where things have already started to come out of the body, which is an immediate surgery. So that's not something. So that's not something we're helping with. That is go see your doctor or go see emergency right away and get things going. Pelvic health has been shown to be helpful, and then also lifestyle management strategies. So we talk about weight, we talk about hydration, we talk about bowel function, we talk about fiber, we talk about how someone is having bowel movements. Because if someone is constipated or they're pushing a lot on their bowel, then that pushes down into the pelvic floor. And if you have any symptoms of prolapse or fullness into the pelvic floor, then that's going to feel worse. So if you can have a good soft
avoid constipation. Tell me a little bit about hydration, because I love my water. I'm a water head.
Great. And so what we typically say, because every body is different, is it's your weight in pounds divided by 2, and that's the number of ounces you should take.
Oh, see, did not know.
So that it used to be the 8 cups a day, but that is not. That is a very generalized term.
Okay, can you repeat this, because this is really important?
Your weight in pounds divided by 2 is the number of ounces you should have.
But then, fairly, you have to weigh yourself.
Yep, I know. I don't have a scale, so I had to weigh myself at work to figure out that I need to have 2.6 liters of water a day, and also I don't think in ounces, so I had to convert it then.
So this is good. I feel like we could talk for another hour, but maybe we'll save that for our next gathering. I want to say that we're going to have more opportunities. I know that we are. Like, I know that this, first of all, menopause and women's health is now starting to get the attention it so greatly deserves and needs. And I don't want to get emotional, but I'm just so thankful.
Yes.
It's great. Because a lot of people, don't know enough. Like, even this, especially the stuff that you talked about today was so, like, again, not literally, but head exploding information, right?
Yes.
and I just, like, I know that people are going to benefit from this. So I just want to thank you from the bottom of my heart. Thank you so much.
My pleasure.
for doing this with me today.
Yeah.
Yeah, it was fun.
Awesome. It's
Thank
good to
you,
be here.
Farrelly. Thank you, everyone, for joining us for Meant to Pause today with Farrelly and myself. I'm Kelly Coulter. We're coming to you from the beautiful House of Owl in Victoria, British Columbia. Thanks again, and everybody have a great day. Bye. We are discussing menopause and politics today. Sonia Firstenau, if you don't already know her, is the leader of the BC Green Party. She is the MLA for the Cowichan Valley. She's been the MLA since 2017, after leading a 4-year battle in Shawnigan Lake to protect her community's drinking water. So welcome to Menopause.
Delighted to be here.
It's a dream come true kind of for me. And Sonia is currently helping with social impact organizations, with strategy, planning, and development. So I'm really happy to have you here also, because I know that you've just got so much going on, and in your wisdom and your brain.
So much going on.
There's so much going on. Yeah, I'm not underestimating, overstating that at all. Today, what I really want to talk about, because this is our political episode, we see kind of a little bit of a thing happening with menopause, in that people are starting to talk about it. We talked today about the cover of the latest cover of Ms. Magazine, where they are mentioning that a movement is beginning, and I believe that to be true. I want to maybe talk to you both about how can we, as members of society, help to make this, I don't want to say a political issue, because I think we're going to talk a little bit about that moving forward. But how can we engage with politicians and organizations that work in the political realm to make menopause more of a priority?
I can jump in.
Yeah.
I'd say about a year ago, I started to realize that menopause was really affecting me. And then I dug into it and looked back on the last decade of my life and realized perimenopause had been affecting me for a good 10 years. And nobody had mentioned this to me. I'd gone to doctor's appointments, I'd talked to people about what I was going through, and a lot of women my age were like, I'm having the same kind of experiences. And it all kind of dawned on me that I had been deprived of knowledge that I should have had. As with most things in my kind of political life, but also in my life generally, rage channels purpose, and then I have to find joy in what I'm doing. And so I have been speaking out very consistently and very loudly about this. And I gave a 2-minute statement in the legislature on International Women's Day, and I said, let's talk about something we so rarely talk about in the legislature, and that's men. Pause. And at the end of that 2-minute statement, it was a very fast, very, I talked about the Jenga tower of demands on women our age, and then you add in all of these symptoms, the hot flushes, the night sweats, the insomnia, the aching joints, all the things that happen to us. And I said, I'm so enraged that I went through this decade blind, like going through a snowstorm blind. And what was so interesting was the women who work in the legislature still to this day come and say, thank you for saying that. I've never heard anyone talk about it that way. I feel so seen. You described exactly what I'm going through. And so I think what's happening is we're all here alone for the most part in this experience, but when one of us starts talking about it and in the role that I'm in, I get a bit more report from most people. The excitement that generates among women our age is enormous because we stop feeling alone.
Yeah. I also felt like I was in a snowstorm. And I don't even think I felt like I was in a snowstorm so much as when it ended, I went, oh my God, what was that?